This is Alicia Belant, and I am here to present to you my Clinical Outcomes Assessment and Practice project for AT 7130 Patient-Oriented Outcomes at AT Still University. The scene for this scenario is within a secondary school athletic training room with patients being high school age student athletes. I recently conducted an informal retrospective analysis of the most common injuries sustained within our selected athlete population. The most common injury was an ankle sprain. Therefore, I will base my scenario on a high school-aged student athlete who has sustained a recent ankle injury. An ankle sprain will cause the athlete pain and swelling through the ankle, and depending on the degree of tissue damage, will also cause loss of motion, strength, and basic function. According to the International Classification of Functioning, which provides a dynamic model of interactions between impairments and functional limitations, these affect the social and societal roles of the patient. These 6 segments of the ICF are health condition, body function and structures, activity, participation, environmental factors, and personal factors. For this athlete, they essentially read as follows. Health condition would be ankle sprain. Body functions and structures would be decreased motion, decreased strength. Activity would be decreased capacity to bear full weight on the affected extremity. Participation leaves the athlete unable to participate in sports activity or unable to perform. Environmental factors include the athletic trainer, physician, physical therapist, which help facilitate appropriate rehabilitation. Personal factors for the athlete is that they have experienced ankle sprains in the past. Due to this patient's likely inability to bear full weight, he or she is undoubtedly experiencing a decrease in the quality of life, which is directly related to their current health condition. Health-related quality of life is an important factor that needs to be kept in mind when managing a patient with an injury that is limiting their functional status. Health-related quality of life brings the patient's psychological and social aspects into the picture and how they perceive these things in relation to their health status. This patient is likely experiencing some degree of loss of identity and depression as they are not able to participate in their sport. They may also lack confidence. They may not be able to not only participate in their sport, but may also be limited with work, which may cause them more emotional stress. Patient-rated outcomes, or PRO, measurement tools are a valuable asset to the treating clinician. They help enhance communication between the patient and clinician and help the clinician direct treatment. For this scenario, a region-specific PRO measurement tool would be best utilized, as it would provide the most relevant information regarding the athlete's perception of their progress through their injury. Now, there are several region-specific PRO tools used. 2 region-specific PRO that are used for patients who have sustained ankle sprains are the Foot and Ankle Ability Measure, FAM, and the Foot and Ankle Disability Index, FADI. Both the FAM and the FADI measurement tools were developed to assess the physical functionality and quality of life of the patient as it relates to their foot and/or ankle injury. Therefore, each are appropriate in the scenario of a high school athlete with an ankle sprain. The FAM assessment has been proven to be reliable and valid when measuring physical function of an individual with a foot and/or ankle injury. FAM has also been shown to have a higher test-retest and responsiveness compared to the FADI. The FAM has been researched far more extensively as far as I have found, and is clearly appropriate, reliable, valid, and responsive, and fairly easy to score. Therefore, the FAM measurement tool used to assess the patient's perceptions regarding physical function is a better tool to use in this particular scenario. Measuring change in an injured athlete's health status is crucial. Without some type of measurement, the clinician will not know when to adjust treatment. The FAM patient assessment tool is designed to help the clinician gauge the patient's perceptions of improvement, with the score being indicative of change. Minimal clinically important differences, MCID, is considered the smallest difference considered to be important when discussing patient status changes using a PRO instrument. MCID for the FAM assessment has been obtained. The Activities of Daily Living section has a MCID of 8 percentage points, while the Sport subscale has an MCID score of 9 percentage points. Both the FAM score, in conjunction with the clinical measurements, need to be considered when measuring change in the status of an individual with an ankle sprain. As far as implementation goes, both electronic and paper versions of the FAM are available. I imagine the paper version of this survey would be much more conducive to a secondary school environment. The patient would be able to fill it out either before or after treatment has occurred. Ideally, the SAM measurement tool would be utilized at the initial injury evaluation and once a week following this, until the athlete has returned to play without restrictions. One barrier I can see with this setting is the amount of time I would anticipate needing to administer, score, and analyze the data. I have not found any data that is representative of the time it would take to administer and score the SAM survey. One way around this time constraint would be to have the athletes fill out their survey on their own either before or after treatment. That way, they will not need my direct, immediate attention until the scoring portion. My time will be primarily spent scoring the survey and analyzing the information. I would also have concerns about athlete buy-in towards the data. Some may feel the need to be dishonest and prove they're doing better so they are able to return to their respective sport sooner. The opposite may also occur when the athlete is not interested in returning to their sport. I feel they may also not take the survey seriously and may try to get through the questions as quickly as possible so they can be on their way. A solution to this problem lies in patient education regarding the survey. If they do not see a benefit to themselves by doing it, there will be no buy-in. I would start by explaining the information collected from the survey will help me understand where they are struggling with their injury. By knowing this, I can then direct treatment interventions to address these specific issues which may help them return to their sport quicker than without this information. For most athletes, I believe this will give them the reason to take the survey seriously.